Thank you for this opportunity to present our data. These are our disclosures. When performing a myotomy for achalasia, it doesn't make a difference if you're doing it laparoscopically or POEM. It's the submucosal space you're trying to enter. And there are concerns that prior interventions may obliterate this space and make it more difficult to enter and subsequently perform your myotomy. Reviewing the surgical literature for Heller myotomies, there's diverging data on the effect of prior interventions when performing laparoscopic myotomies. And the studies on the left here show increased perforation rates, higher postoperative dysphagia, and higher rates for failure. On the right hand, on the other side, you can see that the difficulty of myotomy and postoperative dysphagia did not correlate with prior interventions, and this is seen with multiple studies. As you can see here, the POEM procedure relies heavily on the submucosal space for access and entry, creation of the tunnel, and performing an adequate myotomy. With that in mind, surgeons early on in their experience may be wary of prior interventions in POEM procedures, and this may deter them from approaching these patients with the endoscopic therapy. There is literature in the POEM world increasingly showing that, again, two directions. Some people say it does affect procedure times, prior interventions affect procedure times. Other groups saying that the operative times are comparable and perioperative complications are comparable. So our objective and hypothesis was that we wanted to review our early experience as we just initiated our POEM procedure and at our institution and determine the individual impact of prior interventions on completion of comPOEM and clinical outcomes. We hypothesized that the effect of prior interventions may be limited and should not exclude patients from this procedure early on in your experience. This is a prospective single-center study including 39 consecutive patients performed from July 2014 till March 2016. The procedures were predominantly performed by one of two thoracic surgeons well-versed in endoscopic techniques, as well as one gastroenterologist. The thoracic fellows were involved in every case early on, and their participation was significant early on in the procedures. Unlike prior studies, where interventions were frequently included throughout the cohorts, we grouped patients a priori into three groups according to their anticipated level of difficulty. Group 1, no prior interventions, were patients with straightforward, non-sigmoidal esophagi and no prior interventions, esophageal size less than 6 centimeters. Group 2, we grouped into prior interventions with less than 6 centimeters, but undergone prior dilations, balloon dilations less than 30 millimeters, plus minus Botox injections. Group 3 was more the complex intervention group with patients with sigmoidal esophagi, prior myotomies, esophageal surgeries, or rigiflex balloon dilations over 30 millimeters were included. Our primary outcomes were operative, length of procedure, complications, mucosotomy rates, and needle decompression rates. Our secondary outcomes were quality of life metrics as stated above. Here you can see the distribution of our cases. According to the Chicago classification, we had 10 type 1 aperistaltic achalasia, 19 pressurizing type 2 achalasia, 7 spastic type 3, and 3 other dysmotility disorders, 2 GE junction outlet, EGJ outflow obstructions, and 1 jackhammer esophagus. 39 patients underwent POEM procedure. According to our grouping, 19 were in group 1 with no prior interventions, 11 were in prior interventions with 6 dilations, and 5 Botox injections plus minus dilations, 1 patient undergoing 4 Botox injections at least. Group 3 consisted of 8 complex interventions. 6 patients had sigmoidal esophagi, 2 of which had prior surgeries, fundoplications. A 3rd patient had esophageal repair as a child and multiple abdominal surgeries. There was also 1 patient with pneumatic dilation over 35 millimeters included. 1 patient with a sigmoidal esophagus was aborted early on due to difficulty accessing the submucosal plate safely. She was clipped and underwent a laparoscopic Heller myotomy during the same hospitalization without any complications. Of note, her myotomy was also difficult to perform laparoscopically. These are our demographics: age, gender, BMI, ASA, and follow-up were comparable. Operative time, length of myotomy per length of procedure per length of myotomy, and number of clips required to close the mucosotomy were comparable between groups 1 and 2. Operative time and length of procedure per centimeter myotomy was significantly longer in group 3. While analyzing the adverse events between groups, we noted that one patient in group 1 had an intraoperative complication of a mucosotomy at the GE junction that we were unable to clip. She underwent uncomplicated stent placement for 2 days and stent removal. Subsequently, swallow study showed no leak or extravasation. 2 patients in group 3 required procedures after their POEM. One patient underwent esophagectomy for an end-stage achalasia. She had undergone prior myotomy 15 years ago and was seen by an expert surgeon 5 years prior to seeing us who recommended esophagectomy, and she came to us to perform a final procedure before she had to have her esophagectomy. Another patient underwent laparoscopic hilar myotomy for persistent symptoms. This patient had prior esophageal atresia repair as a child and also had laparoscopic and endoscopic findings of a valid myotomy, but he had persistent symptoms. He didn't resolve after his second procedure either. Interestingly, the rate of inadvertent mucosotomy was highest in group 1 with almost 32%. And besides the one stent placement I mentioned, these were all uncomplicated and uneventfully closed with clips. The use of needle decompression was 45%. There were no known complications from this. Subjective scoring showed that postoperative Eckert scores significantly improved for all groups. Dysphagia scores improved for all as well, reaching statistical significance for groups 1 and 3. Prior interventions, this is also true for quality of life, that all improved. Statistical significance, again, being reached by groups 1 and 3. ANOVA calculations reflecting, looking over all groups, showed that there was no statistical significance for Eckert scores, quality of life, or HRQLs, but dysphagia scores was significant. In conclusion, prior interventions do not appear to impact successful POEM or clinical outcomes. Patients with small diameter dilations and injections are similar to patients with no prior interventions. Patients with sigmoidal esophagi prior surgery and pneumatic dilations have longer operative times, and endoscopists undertaking POEM should consider these groupings during their learning curve. Thank you.